My name is Scott Celinski. I'm a surgical oncologist and hepatobiliary surgeon at Baylor University Medical Center in Dallas. What patients with colorectal liver mets are candidates for surgical resection, and what are the approaches that we take to this? So if you look at patients with colorectal liver mets, there appears to be a significant survival advantage to patients who undergo surgical resection of their metastases, with 10-year survivals being somewhere between 15 and 30%. One of the problems that we run into with this is that there's many patients that are potentially curable that never get a surgical consultation. Medical oncologists have been found to significantly underestimate the resectability of patients with these metastases, possibly missing up to 50% of potentially curable patients for surgical consultation. This is not just limited to the medical community. The surgical community also doesn't understand what can truly be done with these liver metastases. And even general surgeons, colorectal surgeons, and surgical oncologists who do not do liver surgery underestimate the resectability of patients. The other key to these patients is referring them early for surgical consultation, because late referrals often result in missed opportunities for potentially resectable lesions that have either grown to a point where they're not resectable, or resection is limited because of hepatotoxicity, mostly with the irinotecan and oxaliplatin that can cause steatosis and veno-occlusive disease. It's much better to have unresectable patients get a surgical consultation than potentially not sending people who are potentially curative. So when we look at resection and resectability, we've got a couple of things that determine whether or not a patient is resectable. First is going to be the anatomic resectability. And this is not any longer based on the old indications where we used to be limited by the size of the tumor, the numbers of tumors in the liver, or whether or not it was bilobar. This is really just based on, can we surgically get it out? And the only way that you're going to be able to truly evaluate that is really having a liver surgeon evaluate them. The other issues become functional status. So the patient needs to be able to tolerate the operation that they need. And so this is a moving target, because there certainly are smaller operations that are needed that somebody may be able to tolerate, but they may not be able to tolerate a much more major resection. Age itself is not a contraindication. It's really more the functional status. So I always tell patients it's not the model year, it's the miles on the car that really matters as to what we can do. And then other considerations are going to be extrahepatic disease. If they have extrahepatic disease, that is not a contraindication, but we need to have a plan for addressing that extrahepatic disease, whether it be also surgically or with other methods. So factors that are going to include or increase the likelihood of recurrence, but not necessarily preclude resection, are going to fall under size, number, the disease-free interval that the patient has had, whether or not they have extrahepatic disease, elevated CEA levels. These are useful in prognostication, but not really for exclusion. And so then when we kind of look at the approaches for surgical resection, we really have quite an armamentarium for doing that. So we can look at straight resection options, cutting it out, whether that be open operations or minimally invasive. We have ablation techniques, combinations of the two. We can do multi-stage operations for more advanced disease. And then when we look at the status of their primary tumor, if they present with synchronous metastases, we can look at doing synchronous resections sometimes, or sometimes we do staged resections. And depending on the extent of their disease, we may do the primary tumor first, or we may look at doing a liver first approach. This generally is determined based on which aspect of their disease is more advanced. And we tend to address the most advanced portion of their disease first, because if we end up with not being able to potentially cure that aspect, it doesn't make sense to go after the other portion. And then we look at, when do we do surgery for these liver metastases? Do we look at an upfront resection, which generally is going to be done in patients that have a longer disease-free interval, fewer metastases, a simpler operation, versus perioperative systemic therapy or looking at adjuvant systemic therapy. Um, Again, early referral to surgeons is important, especially in the more advanced disease, which is a little bit counterintuitive. Those are the patients that you might be thinking shouldn't see a surgeon. But one of the things that we run into is overtreatment. Again, the liver toxicity really can limit our ability to resect patients. So it's important for the surgeon to get involved early for planning and limit the chemotherapy before an operation, and then look at doing additional treatment afterwards.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
All patients with metastatic colorectal cancer at diagnosis should be at least considered for a path to achieve curative resection. So any patient that I see personally in clinic, no matter what their CT scan looks like, I will look for a way to render them potentially surgically operable with the hope that they would be cured. But we also know that the optimal patients to select and the optimal treatment regimens are really unclear. There have been several studies that have looked at the response rate, at the R0 resection rate, and even the surgical curability rate. But Punt et al. Presented at ASCO 2022 a late-breaking update on their randomized trial of the triplet FOLFOXIRI plus Bev versus the doublet selections of either FOLFOX or FOLFIRI plus bevacizumab for initially unresectable colorectal cancer with liver metastases. This is the Cairo 5 trial. What they reported were the right-sided and/or RAS-RAF mutated patient population. There is a portion of the trial for the left-sided and/or RAS-RAF wild-type patients that has completed accrual as of May 2022, but the final results are not out yet, likely because those patients are doing much better. So for the right-sided or RAS-RAF mutated patients, 294 patients were randomized 1-to-1 to the doublet FOLFOX or FOLFIRI Bev versus the triplet FOLFOXIRI plus Bev arms. At a median follow-up of 40 months, the median progression-free survival was 9 months for the doublet and 10.6 months for the triplet, which was statistically significant. The objective response rate was 32% for the doublet versus 52% for the triplet. But of course, as expected, the adverse event rate was also much higher for the triplet group, especially neutropenia and diarrhea. So considering these studies, one would be tempted to consider that patients who might be potentially rendered surgically operable should receive triplet therapy with FOLFOXIRI and bevacizumab. Although again, the left-sided data is still pending, and the overall survival overall analysis of both groups, left-sided and right-sided, was the nature of the study from the outset.